Dear friends, welcome to this webinar series on neuroinfections. I think at the beginning, I need to acknowledge the graciousness of the directors of the FINE, Dr. Sudhir Kothari and Roop and Rahul and Dr. Meshram, for having taken up this most important topic. With this, I invite the director of this webinar series, Dr. Chandrasekhar Meshram, who is past president of the Indian Academy of Neurology and currently is the chairman of the Tropical Neurology Research Group of the World Federation, to take on from here and give his welcome address, which would be then followed by the inaugural address by Professor Raj Shakir. Dr. Meshram, please.
Yeah. Share screen. Dear friends, good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology and Forum for Indian Neurology Education, I welcome you all for this WFN-FINE Neuro-Infection series. On board today, we have Professor Raj Shakir, Professor Wolfgang Griswold, Professor Katrar, Professor Prabhakar, Dr. Pramod Kumar Pal, Dr. Gagandeep, Dr. Rahul Kulkarni, Dr. Sudhir Kothari, Dr. Manish Modi, Shripad Pujari will soon join, and I welcome you all. Infective diseases are often neglected, but Corona has taken the world by storm, and people all over the world started realizing the importance of infective diseases. Corona has changed the life for many. After the successful Intropicon at Mumbai in 2017, and then Intropicon 2 in Sao Paulo, Brazil in 2018, we were planning for the third one in African country. But because of COVID-19, things have changed. So, Tropical and Geographical Neurology Specialty Group of WFN has decided to have a webinar series on neuroinfection. FINE had come forward to collaborate and provide necessary assistance. We are grateful to the WFN for endorsing this series and guiding us. I would like to mention that Tropical Neurology Specialty Group is the first group of WFN to come forward and organize such an educational activity. We have about 1,400 delegates registered for this program. When we started communication about this meeting, neurologists across the globe, including WFN President William Carroll, appreciated the initiative, and they were happy that this program is dedicated to late Professor J.S. Chopra. Professor Chopra was associated with WFN since 1985. He had very successfully organized 14 WCN in 1989 at New Delhi, India. He was editor of World Neurology for about a decade. He worked on many committees of WFN. He was founder president of Indian Academy of Neurology. He was professor and head Department of Neurology at PGI Chandigarh for about 30 years. He had trained many students who are doing extremely well all over the world. He strived for the development of tropical neurology. He edited the book Neurology in Tropics. He received many awards. The most important were Padma Bhushan by the President of India in 2008 and Lifetime Achievement Award by WFN in 2017 during tenure of Professor Raj Shakir as WFN President. So we thought this was a right moment to salute our teacher and mentor. For today's program, we also have Professor Griswold, who is the Secretary General of World Federation of Neurology. and special interest in education. And we all remember the excellent WSCN conference he organized in Vienna in 2013. I requested him today morning only, and he agreed to join. Thank you very much, sir, and warm welcome. We also received best wishes for the success of program from President Professor William Carroll. Who could be a better person than Professor Raj Shakir to inaugurate this event? He is immediate past president of WFN and chair of specialty group of WFN. He is the chair of Neurosciences Tropic Advisory Group of WHO, and due to his efforts, stroke has come from cardiovascular diseases under cardiology to cerebrovascular diseases under neurology. He was previous chair of Tropical Neurology Group. He has written 2 books on tropical neurology. He is a driving and guiding force for tropical neurology specialty. We welcome you, sir. We don't want to do what we want, but we want to do what you want. Therefore, we will highly appreciate your feedback. Enjoy the series on neuroinfections. Thank you very much.
Right. I'm sorry, I forgot to unmute myself. Sorry about that. Thank you, Dr. Meshram. It's now my great pleasure to invite the chief guest of today's web function, Professor Raj Shakir, who is from London and also the former president of the World Federation of Neurology. His links with India are formidable. And we have really fond memories, Professor Shakir, of your visits to India. And I can recall at least 3 of them in the recent times, but I'm sure there must have been many more. And of course, I think the most favored nation status that we enjoyed during your presidency. Dr. Shakir, I request you to kindly give your inaugural address and also to light a candle. Am I right, Dr. Mishra? Dr. Shakir, please.
Yes, yes, you are right. Thank you. Thank you, Gagandeep. Thank you, everybody. This is a wonderfully organized event, and it only shows that the WFN is correct when in 1957, the the Commission on Tropical Diseases, it was called the Commission, was inaugurated. You all know the history of the WFN, and in the history it's very clear that the first problem commission was tropical neurology, and it had 2 sections, East and West. So because it was a huge topic, today, as you see, our first speaker is from the West, is from Lima, Peru. And I just want to show 3 slides. I don't know if the slides can be shown, please.
You'll have to share your screen.
Share my screen.
The slides, Mansi.
Okay.
Look at the bottom of your screen, you will find a green thing, share.
Yeah.
The green share screen, yes.
Yeah. So now I have to go to my, I'm sorry, it says share as well, share.
Good. You made it.
What? Not yet. Not yet. I need to show you the slides here, and it's only showing my emails. So I think this is my first slide. Are you seeing the slide?
Yeah, they have come.
Yeah. Okay.
Yeah.
So this was the first meeting of the organization, and you can see I've highlighted Dr. Trellis here, number 6. This is And Dr. Trellis is a very important person. He's from Lima, Peru. He eventually became the president. So he's a very, very important neurologist. And the reason for me to show this is to move to the next slide, which is when the commission met for the first time. And all of you from India will recognize this person here on the left. He was a mentor, I think, for, if I say all of us, including myself, Noshe Wadia, when he was attending the meeting in Buenos Aires in 1961. On the way back from there, he was arrested and put in prison in Lisbon because of Goa, let's put it that way. So I don't know why the screen went like that. And this is the slide which I want to show you the individuals of today. Charles Poser, top left here, was instrumental. He visited India immediately after the establishment of the WFN, came to Mumbai, and then to Kolkata. And Charles established with Nosher the tropical neurology group, and this was taken over by Jagjit Chopra. I will not go, and for my colleagues in India, I will not say who these people, they are giants of neurology, not only in India, but across the world. And there is Oscar Trellis from Lima, and this connects us to the first speaker, Hector Garcia. So I can go on about the history of tropical neurology, and there is a lot of it. It is still, to me, it is the most important specialty group in the WFN, and there are 16 of them. I was very, very honored to be asked to chair the specialty group of the WFN. And I think this group, the Tropical and Geographical Neurology Group, is the most active one, and we are delighted with that. As you know, the topics that go on every Saturday until September are varied, and the speakers come from Asia, from Africa, and from Latin America, which exemplifies the scope and the breadth of our specialty. And Jagjit Chopra was mentioned, but his latest book on tropical neurology, and those who want to read the history, Dr. Bhattacharya from Kolkata wrote a beautiful chapter in that book for those of you who are interested to read about history. And as you can see here, the topics are varied and the speakers are varied. And next week we have Eric Schmutzhardt from Austria. Then we have, I'll make this bigger for you to see. And we have Marco Medina from Honduras, who's the president of the Pan American Federation, Riyad Guaider from Africa, who is currently a trustee of the WFN. He will demit later this year. Dr. Usturk from Turkey, James Day from Vietnam, and Avendranath and Joseph Berger from the USA. You are all welcome to join these weekly webinars, and I'm sure we will all learn a lot. So at the end, I just want to again thank you very much for honoring me to ask me to participate today, and I hope that we will all have a wonderful time listening to all these speakers from across the world. So I think at this time, please correct me if I'm wrong, do we light the candle now? What is the procedure? Okay. Gagandeep, you advise us.
Light the candle now.
Okay, thank you. I hope you can, I hope you can see the candle. If I double click on this. No, actually, right?
You have to stop sharing your screen.
You hold the candle in your hand.
I'll hold it in my hand. Yeah, but can you see me now? I don't think so.
Yes, we can see you.
Okay, okay. I'll light it first. Here you go.
Wonderful.
Yeah, wonderful.
I hope you all see it.
Thank you very much.
Thank you very much. Thank you.
Nice big fat candle. Good.
It is, yeah. It's going to last for the whole. I'm planning to keep it for the whole of until September.
Okay. Right.
Thank you.
Thank you.
Thank you, Professor Shakir. Thank you so much for the wonderful historical going back in history of the World Federation and the Tropical Neurology Group. Might I take this moment to request the Secretary of the World Federation of Neurology, Dr. Grisold, to briefly address the webinar, please. Dr. Grisold, are you there?
Yes, I'm here.
Yes,
I hope you can hear me. Thank you.
Very well, very well. Yes.
Thank you. I'm very honored to participate, and it came quite unexpectedly, so please excuse my outfit. It's not disregard, it's just cycling, and I just stopped to participate. I think it's an excellent initiative, and what we learn now is that we all have to learn to do virtual meetings and virtual sessions. And I do think in the moment it's the only solution that we have, but I do think that it will develop even more of that. And many Congress organizations are now planning to do future Congresses live, but in addition have something else also in virtual. They call this hybrid, although nobody knows what hybrid is in the moment. But it seems to be the tendency, and this was what I heard from a Congress organizing committee, Congress last week, that even more people are interested if they can partially participate virtually, and it raises the interest for topics. So in that sense, I think you do an excellent job, and that's an excellent idea that you have. There will be also another specialty group that will do something on Africa on a special education day. And I think, as Rad said, you're the first ones, and that's a special merit to put this on the track. So I congratulate you again for doing this initiative, making this possible. And we all know how difficult it is to get people, to get funds, to organize everything. And I wish you the best of luck for that. And I look very much forward to your presentations. Thank you very much.
Thank you, Dr. Grisold. Thank you so much. We now get to business, and I would request the chairpersons of today's webinar to take the online stage from now onwards. So it's my pleasant duty to invite Professor Sarosh Katrak and Professor Sudesh Prabhakar. Dr. Katrak is from Mumbai. It's very well known. I don't need to give an introduction for either of them. Sirs, can I request you to take on stage from here onwards to introduce the guest speaker and take things forward? Right.
I'll introduce the topic first. Now, COVID-19 pandemic has affected nearly 14 million individuals worldwide and has been consuming the headlines for the last 6 months. Neuro-Cysticercosis, which affects nearly 50 million individuals worldwide, has hardly attracted any attention. No wonder that the WHO has called it the neglected tropical disease. It is endemic in sub-Saharan Africa, Latin America, and Asia, and India, it is also endemic. The most common manifestations of neurocysticercosis is seizures. And this in developing country accounts for 50% of epilepsies of late onset. There are other manifestations like rise of intracranial pressure, focal deficits, and psychiatric manifestations. Today we have a world-renowned expert to speak on this subject, and we are really fortunate to have Dr. Hector Gracia. I'll request my co-chair, Professor Prabhakar, now to do the honors of introducing Professor Hector Gracia.
Hello. Can you hear me?
Yes.
Yes, we can hear you.
Yeah, okay, fine. Gagan, can I have a slide or should I just go on speaking? Okay. Well, good evening, everybody. It's our pleasure to be here and chair this session. I'll introduce our speaker for the day, Dr. Hector Garcia. He's the coordinating member of the Cysticercosis working group in Peru. Dr. Garcia graduated from Hardia University in Lima in 1989. He later obtained his PhD in international health at Johns Hopkins Blooming School of Public Health in Baltimore, USA in 2002. He is author of about 150 papers, multiple book chapters, and the main interest has been in the neurocysticercosis. Dr. Garcia is the currently professor at the Department of Microbiology of the Universidad Peruna Queteno Herdia, director of the Center for Global Health Tumbes in the same university, and head of the Neuro-Cysticercosis unit of the National Institute of Neurological Sciences in Lima, Peru. We all know his interest in the neurocysticercosis, and I'm sure we are going to learn much more from him today. Dr. Hector Garcia, please.
Hi, it's such a pleasure to see that many authorities and friends. And I guess we can begin with the talk. Professor Meshram, Professor Dr. Sudhir.
Yeah, we can continue.
Yes, Hugo, if you could start off, would you like to share your screen?
I think Professor Dr. Sudhir is going.
No, I think you need to share your screen, Hugo.
Yeah, it's coming.
Okay,
Yeah.
Right.
Dr. Sudhir, is this going to show up with the audio?
So do you want the audio also?
Yes.
Yes.
Okay.
To open this series of webinars, and it's a particular pleasure and a honor that it's distributed to Professor Chopra. Along the next 40 minutes, we will talk about cysticercosis, which still is a significant cause of neurological morbidity in most of the world, particularly in poor countries. The first thing I have to say is whatever I'm going to show you is not personal work. It's work by a large group of people from different backgrounds and different institutions that have been working together in studying cysticercosis for more than 30 years now. And we call the Cysticercosis Working Group in Peru. And you can see a picture, a group picture in this slide. And whatever I'm going to show you is group of everybody and not a personal achievement. So the first thing we have to say is cysticercosis is present in most places where pigs are raised. And that means basically every developing country except for pure Muslim countries. And poor people raises pigs because pigs are easy to grow and you don't have to invest in feeding them. When you leave a pig free, the pig will go and find food by itself. And on the way of doing this, it will find human stools. And unfortunately, pigs like shit. They will eat stools, and whenever T-solium is present, they will eat contaminated stools with eggs and have cysts in their flesh. But we will talk about the cycle in a second. First, let me show you the world map of cysticercosis infection by WHO. Well, this has to be wrong, it's WHO. But you can see that most of the tropical belt is endemic for cysticercosis and also expands to many other areas. The life cycle of cysticercosis, of Taenia solium, it's a classical life cycle of a complex parasite. The parasite has an adult tapeworm and a larval population. The adult tapeworm, in this case, it lives only in the intestine of humans. So humans are the carriers of the tapeworm and the source of infection with cysticercosis for pigs, and unfortunately also for other humans. It will be ideal that we can be restricted to having the tapeworm and not having cysts, like in the case of Taenia saginata. But unfortunately, in this tapeworm, humans can also be an intermediate host, have cysticercosis, and be infected by fecal-oral contamination. So, coming back to the cycle, when a human ingests a piece of contaminated pork containing cysts, the head of the tapeworm, the scolex, which is in the cyst, gets out, evaginates, and attaches to the mucus of the human intestine. Then, using the head, which has suckers and hooks, it will hang up from the mucus and develop an entire tapeworm that measures 2 to 4 meters. The growth of the tapeworm occurs at the neck region, where these little segments of proglottids are formed, and as new segments grow at the neck region, the older proglottids become distal and more distal up to the end of the tapeworm. In this process of maturation, the proglottids develop a very raw nervous system, a digestive system that absorbs nutrients from the tegument, and a fully developed genital system. This is a hermaphroditic worm. It has male and female genitalia. And at some point, it self-fertilizes. So the final proglottids, those that you see at the right side of the screen, are gravid proglottids. You can see they are swollen, completely occupied by a gravid uterus. You can see this in this picture. And the gravid uterus is filled with 30,000 to 60,000 infective eggs, each of which can become a cyst in a suitable intermediate host, be it a pig or be it a human. You can see here the egg as you see in microscopy of stools, and at the right side, a beautiful picture from a book of Anna Freezer in the 80s, where you see the embryo in the interior of the egg. And this embryo is sized a little bit larger than a red cell, which probably explains why, unlike hydatid, it doesn't stuck filtered in the liver or in the lungs, and most of the times it distributes to all tissues, including the brain. So coming back to the cycle, we have the human tapeworm carrier as the sole source of infection for pigs and for humans. And in humans, of course, we can have cysticercosis in any part of the body, where it may survive or it may be destroyed by the immune system, but where cysts are going to be problematic in terms of symptoms and morbidity is when they go to the central nervous system. And that is what brings us to this conference talking about symptomatic human neurocysticercosis. We always have to remember that this is an infectious disease. So for any symptomatic case we see in hospitals, there are many other people that were exposed to the worm and infected and perhaps resolved the infection by itself or never developed symptoms. Patients come to the hospital for many different neurological symptoms, but the most common is late onset epilepsy. And some of them will come from intracranial hypertension. One thing that I consider key to understand neurocysticercosis is to understand that there are many different clinical presentations that will derive from the number of parasites, their volume, their location, and the inflammatory response of the hosts. So the first thing is to split it, and probably the more intuitive splitting is in two big boxes. When cysts are in the parenchyma of the brain or when cysts are in the extraparenchymal space, they really configure two very different diseases. When cysts are in the brain parenchyma, they will eventually disappear, get destroyed by the immune inflammatory response. Some of them will calcify. And in general, the problem here is seizures and epilepsy. But this can look very, very benign, and it's particularly benign in the Indian subcontinent. We will talk about that later. But in some people, cysts may persist alive in the brain for years or even for decades. So whether it is a role for destroying the cyst with antiparasitic drugs or not will be appreciated different depending on the type of cysticercosis we are talking. Again, we will get into that in a few minutes. So this is the same slide with a few pictures to show you how a viable cyst looks like. And then once the host inflammatory response destroys it, it becomes an inflammatory enhancing lesion or a granuloma and eventually disappears. And a proportion of them will leave a residual calcification. This is a typical patient as we see in Latin America, people in the 30s, 40s, or 20s with a few viable cysts in the brain parenchyma coming for seizures. One of the things you have to notice here is that the cysts are perfectly viable, pretty well established, and the parenchyma around the cysts look perfectly healthy, talking about a great homeostasis between the host and the parasite. Have another picture here. These are two small cysts in the left parietal cortex on CT to show you the difference between the images on CT and MRI. And here we have an occipital large cyst in which you can notice something has changed. Now we have inflammation. The blood-brain barrier has been broken. You can see the lower part of the cyst enhancing with contrast, which means the blood-brain barrier function is impaired. And you can also see the occipital lobe much darker, reflecting edema and the local inflammatory reaction. This marks the point where the host's immune system is attacking the cyst, and it will end up collapsing the cyst and destroying it with cellular infiltration and a cytokine reaction. And then the cyst collapses into an enhancing nodule. This is the most typical presentation in the Indian subcontinent. We will get to that in a minute too. And then this ends up with disappearance of the lesion or with its calcification. In a few patients what we have is hundreds or thousands of small cysts with a diffuse inflammatory reaction. This form is known as cysticercosis encephalitis, and it's important that you get familiar with it because the problem here is the diffuse inflammatory reaction. So the care of these patients should be primarily focused in decreasing inflammation. If you go with antiparasitic drugs, you will release more cystic antigens, worsen the inflammation, and you may kill the patient. Of course, there are other patients that are probably past this step and show up at the hospital with many, many cysts and no traces of inflammation. In both cysticercosis encephalitis or massive non-encephalitis cysticercosis, it's very frequent that the patient is carrier of a tapeworm. Now we move into extraparenchymal neurocysticercosis. The mechanisms of disease in extraparenchymal neurocysticercosis are very different, and the worst of them is in the case of subarachnoid cysts. Cysts in the ventricles on the subarachnoid space are not associated to seizures. Mostly they will manifest as mass effects, hydrocephalus, intracranial hypertension, and this type of disease is associated with significant sizable mortality even in the best care scenarios. And one of the problems that we'll see here in the subarachnoid disease is that the cystic membrane grows and expands. First, let's talk about cysts in the ventricles. They are usually in the cystic shape stage, and mostly they will trigger manifestations by blocking the circulation of the cerebrospinal fluid. And you can see here one in the left lateral ventricle. But when the cysts locate in the subarachnoid space, like the Sylvian fissures, the parasitic mass grows and expands like a cluster of cysts or a giant cyst, and they occupy space and behave as slow-growing tumors. You can see here the midline deviation in this patient. And the worst of them, the worst of these subarachnoid cysticercosis types is when the basal systems are infiltrated by the parasitic membrane, and this goes along the spaces, infiltrates, occupies the space, grows, and triggers a local inflammatory reaction that will cause a very thick CSF with lots of proteins, lots of cells, and in some cases even low glucose. This is a picture to show you how subarachnoid cysticercosis looks like at necropsy. And what you see as vesicles, they are not individual cysts. It's basically CSF or cystic fluid trapped in membranous expansions of a complete membrane magma expanding through the subarachnoid space like a chronic arachnoiditis. So in the past minutes, we went through different patients, and they have different types of cysticercosis, which will mark different clinical manifestations, different evolution, different treatment approaches, and even different diagnostic approaches. But let me just a few words to signal how the clinical spectrum of neurocysticercosis can differ between zones or regions. In heavily endemic regions like Latin America, Africa, parts of China, what we see is many patients with multicystic parenchymal disease, subarachnoid cases, a sizable number of people with calcified disease, and the numbers of people with single degenerating lesions are smaller, and the presence of the tapeworm is more or less frequent. However, in the same regions, when we look at what happens to the pediatric population, In the pediatric population, the majority of cases come with a single degenerating lesion. Still see a few people with cysts or with calcifications, but most of them come with a single degenerating cysticercosis. And here there is a very interesting characteristic, is that we can find the tapeworm in the patient, more than in the patient, in the close environment very frequently, very likely because the short lifespan of a kid, it's still overlapping with the lifespan of a tapeworm, while in adult people, the patient comes for care years after infection, and the tapeworm, as most of the times, is not findable anymore. Okay, but how about the Indian subcontinent? India, for us who look it from outside, has a very different spectrum of disease to the Neuro-Cysticercosis cases we see in Latin America. The whole literature is very consistent, and we even have visited Dr. Rajshekar and Dr. Singh in a few prior occasions, and definitely it seems that most cases in India are people in the second or third decades of life showing with a single or a couple of degenerating cysticercosis. And the other presentations are less frequent, and finding a tapeworm is less frequent. How about travelers? If we look at travelers, the spectrum is very similar to that found in pediatric populations or in India, mostly a single degenerating parasite. But if we go to Europe or United States and look at the immigrants that have been living there for 10, 15, 20 years and show up for medical care, then we come back to people with viable cysts or subarachnoid disease, which are probably the forms that take many years as viable before manifesting with symptoms or with mild symptoms for a while. So basically, we are looking at different populations, and what we hypothesize is that what you see in India, it's probably the natural history of evolution in the human beings. So a human is supposed to be exposed to a mild challenge with a few eggs, and probably his or her innate immunity, native immunity, can overcome this infection and resolve it by itself, leaving it to degeneration, disappearance, and calcification in a proportion of times. While in heavily endemic areas, probably what we are seeing is larger burdens of challenge with more eggs or more infection pressure, more transmission, probably overcoming innate immunity and establishing as long-term infections where the cysts live in the brain for years or even more before they degenerate and calcify. Why is this important? Because it will explain the perception of attendings in the Indian subcontinent and in pediatric wards in the States, where cysticercosis is perceived as a mild disease compared to neurologists in heavily endemic areas, where most of the patients come with multiple cysticercosis and protracted clinical courses. But there is also ocular cysticercosis. It's less frequent, but still occurs. The National Eye Institute in Lima sees about 10 patients a year. And you can see this beautiful picture of a cyst floating in the vitreous and with the retina at the back. Cysticercosis also go to all the tissues, including muscle. And in muscles, it's usually found by chance. Somebody has an accident, they break a leg, they take a scan, and you can see the scars, calcified cysticercosis. And in this one, you can see it very nicely in 3D reconstruction of a computer tomography. how the calcifications are elongated. This is has been clearly described since the old British literature. And this is because the cyst dies and it's subject to the pressure of the muscle bundle that ends up as a longitudinal cigar-shaped calcification. Now we move on into diagnosing cysticercosis. My friend Oscar del Bruto in Ecuador has been coordinating a set of diagnostic criteria to be used to homogenize criteria between different groups in different regions to be able to speak the same language. The first version of this was published in 1996, and then there was a second one in 2001, now focused in Neuro-Cysticercosis, and the most recent review came out in 2017, and the most important changes into the revised version is that now it focuses primarily in neuroimaging as the primary tool for diagnosis, with other tools as contributory or confirmatory tools for the diagnostic of the disease. This set of criteria is very useful to make sure that all people in different places are speaking the same language. However, when we come into the day-to-day practice, how can we summarize the diagnostic approach for neurocysticercosis? Well, I will say that the diagnosis is based in neuroimaging, and it could be CT or MRI. MRI has better images than CT, but has the problem that in most of the cases it will miss small calcifications because of the nature of the technique. And neuroimaging is not always 100% sensitive or specific. So the support of an accurate serological test, it's very helpful. And in serology of parasites, there is the problem that many parasites share antigens, and cross-reactions are very, very frequent. The issue of cross-reactions was approached by Victor Sang at CDC by involving a new technique called immunoelectrotransference or enzyme-linked immunoelectrotransference, EITB, using a purified set of parasite antigens. And this Western blot or EITB has a huge advantage in sensitivity and specificity over the existing antibody detecting ELISA. And there are 7 specific antibody bands that you can see in the picture. They belong to 3 different families, and now the more recent literature is showing how these families reflect different stages in the infection of cysticercosis. There is also the possibility of looking for antigen of the parasite instead of looking for antibodies. The antigen of the parasite is more precise because it marks the presence of a live parasite, is not present in dead parasite infections or resolved parasite infections. And this is, unlike antibody detection ELISAs, these antigen ELISAs are specific because they were developed on the basis of monoclonal antibodies raised against Taenia saginata. The initial test was produced in Scotland, and very soon after there was a second test produced in Belgium by the early 1990s. And this test is not as sensitive as the Western blot because the antigen has not been multiplied by the immune system as the antibodies are, but in general it's quite specific when it's applied in human populations. In pigs, it crosses with Taenia hydatigena, but it's not a problem for human diagnostic. This test is not as sensitive as antibody detection, but in cases where antigen is positive, it's a great test for following up patients along its evolution. This is a case, you can see the MRIs in the top row, and it's a very bad subarachnoid cysticercosis case. And the blue columns, the dark columns, represent cycles of antiparasitic treatment. The dotted black line is the area of the parasite on the MRI, and the blue line is serum antigen levels measured in stored specimens of this patient. And you can see how the antigen basically parallels the amount of parasite and becomes negative at the same time or even a little bit earlier than the resolution of the parasite images on MRI. So now we are using more and more this test as a tool to follow up our patients in the evolution, in the clinical evolution and post-treatment. Probably the most interesting story in neurocysticercosis is what happened to antiparasitic treatment. I will say the key point in this story is basically 1979. Two things happened more or less by this time. One is CT is made available, and the second one is somebody in Mexico, a veterinarian, tried praziquantel in infected pigs with schistosoma, and to his surprise, he found dead cysticerci. So he went and bought another set of cysticercosis infected pigs from an endemic town, treated them with praziquantel, and demonstrated that it actually killed the cysts. It was the first specific antiparasitic drug available. Before that, the only thing people had was surgery, steroids, or necropsy. So once praziquantel works, people begin to use praziquantel, and CT shows that the cysts disappear after praziquantel therapy. So this is kind of the onset point of the story. And this is the report, the initial report of a case treated with praziquantel in Mexico. The veterinarian went to a friend of him, a neurosurgeon, and they treated a kid with multiple inflammatory cysticercosis. And thanks God, the kid evolved very well. They published the case, and to show how publication ethics has changed in the last 4 decades. You can see at the lower right hand, the last page of the paper, where there was a picture of the smiling face of the kid. And the conclusion of the paper was, we have a drug that kills cysticerci, dog is dead, rabies is over. Unfortunately, it was not that easy. When people began to treat patients with praziquantel, some of them had bad reactions in the initial days of treatment, seizures, intracranial hypertension, and the Brazilian team led by Dr. Spinafranca, they rapidly interpreted this as an inflammatory reaction to the death of the parasites and suggested the addition of steroids. So people began to give praziquantel with steroids, the side effects reduced. By those years, another group in Mexico demonstrated that albendazole was also efficacious to kill cysticercosis. And at this point is when some groups begin to question whether do we really need or do we really want to kill the parasite with antiparasitic drugs. So before we go into the controversy on using antiparasitic drugs, please let me have you consider the difference on the type of patients seen in the clinical practice of pediatricians in the United States or neurologists in India, who saw mostly people with a single degenerating granuloma, compared to people in more heavily endemic regions seeing patients with multiple viable cysts and a higher frequency of subarachnoid cysticercosis. So then you will understand why there were such different views, and probably it originates from them talking about very different disease spectra. So, people who were in favor of using praziquantel and then albendazole said, well, you can see that you kill the parasite with the drug. And they also said, if you look around, compared to 30 or 40 years ago, we don't see those bad chronic cases of subarachnoid cysticercosis with chronic hydrocephalus and blindness that we used to see in the neurology wards. And they also say that if we kill the parasite, we will have fewer seizures in the long run. And they also said that there will be fewer residual calcifications. This has not been proven yet. On the other hand, people who were not prone to use antiparasitic drugs basically say that this was an expected cyst degeneration and marked the death of the parasite, and so there was no need to complete the process by using a drug that will trigger more brain inflammation, and particularly if you can face serious side effects. And one of the key words here that was not quite taken into account at the beginning of the discussion, and it's more and more evident as the years pass, it's brain inflammation. So definitively, if we are going to try to treat the parasites in the brain with an antiparasitic drug, modulating brain inflammation is a key part of the process. This is a CT of a patient who was being treated with albendazole and steroids, in whom steroids were reduced too fast, and she developed this encephalitic-like syndrome that luckily resolved in a few hours after reinstalling intravenous dexamethasone at higher levels. So in order to continue discussing treatment, I will say that we have to contextualize treatment into different clinical presentations. We have to understand that not everything in treating cysticercosis is antiparasitic drugs. There is a major role for symptomatic drugs. And we also have to locate that there is not such a thing like a free lunch. If you let the parasite alive and don't treat it, there are some risks. And if you treat the parasite with the drug, there are some risks. Some preliminary evident conclusions are that you have to be taking account very seriously judicious use of symptomatic therapy, particularly antiepileptic drugs and analgesics. They should be optimized way before you decide to use antiparasitic drugs. Then, if you have a large cyst, which is behaving as a tumor with a mass effect, you have to do something. You cannot just let it be and grow or increase or continue causing mass effects in the brain of your patient just because there is the theoretical possibility that it will die someday. Finally, if you are going to use antiparasitic drugs, you have to tailor it to the individual patient circumstances and the type and degree of severity of the cysticercosis you are treating. And if you try antiparasitics, there's no reason why not use concomitant steroids. So many years ago in Peru, we had a gathering of experts, and we crafted a paper on consensus on treatment. And by that time, the experts agreed that if your patient had between 5 and 50 cysts, you probably will do better treating all of them at the same time with antiparasitic drugs than waiting for each of them to die at different timing. At that time, we also concluded that if you had a single degenerating cyst, there was no need to use antiparasitic drugs, and probably anti-inflammatory management with steroids was enough. We were wrong. And also, we say that there was no need to antiparasitic treatment in dead parasite, which seems very evident. And one of the advanced things in that paper was to suggest that ventricular cysts should be managed by neuroendoscopy. And it actually proved very, very helpful. And today there's like 100 papers stating the advantages of minimally invasive surgery in ventricular cysticercosis. Of course, if you have subarachnoid cysticercosis, we have no option but to long courses of antiparasitic treatment. And if you have hydrocephalus, you first worry about the hydrocephalus and then worry about finding the cysticercosis. But all of this is kind of generic, and most people want a yes-no answer. Do we use antiparasitic treatment or not? By the 2000 to 2004, we did a large trial in 120 patients with cysts or inflamed cysts, in which we compared whether people treated with albendazole and steroids versus people treated with 2 placebos will do better in terms of disappearance of cysts and seizures. That paper showed that the placebo group didn't disappear the cysts and that there were fewer seizures with generalization in people treated with albendazole. So our conclusion was that in general it was better. And from then on, there are several other papers that have come to similar conclusions in terms of fewer seizures. There was one paper about fewer seizures with generalization. There's another paper with fewer seizures in people who resolved all their cysts. And in general, the consensus is that you will have fewer seizures if you resolve your cysts using antiparasitic treatment. But when you look at single enhancing lesion trials, and there are very large and pretty well done trials in India, the conclusion on radiological resolution is not that crystal clear. You can see this meta-analysis. 2 were very close to no effect, 2 were strongly positive, 1 was strongly negative, which actually is biologically non-intuitive. There's no reason why you give albendazole and the cyst. It will take more time to resolve. But the interesting thing is, if you look at the seizure numbers in these trials, you have this pretty homogeneous meta-analysis. And the interpretation currently is that giving antiparasitics plus steroids to people with a single enhancing lesion, it's probably associated with a reduction in the expected number of seizure relapses. Of course, there are other factors like the likelihood of having a residual calcification. People who calcify their lesions are associated with more frequency of further seizures, etc. And a couple of slides to show you how bad subarachnoid cysticercosis can be. You can see here the invasion of the right Sylvian fissure and the paraventricular spaces in the left hemisphere. And this is another picture of the same patient. And what will be then the message? For us, for our team, we think that destroying the cystic cell with sound use of antiparasitic drugs and steroids is beneficial in most patients, but you have to define which type of neurocysticercosis are you treating, and you have to have in mind that killing the parasite is never an emergency. Symptomatic therapy and stabilizing your patient is extremely important before taking the decision of beginning antiparasitic therapy. From then on, we have published a couple of papers showing that combining albendazole and praziquantel is more efficient in destroying the parasites, and probably we're using too little dexamethasone. This trial proven a much higher dose for a longer time and found fewer seizures during the initial couple of months. In 2017, the U.S. Infectious Disease Society and the Society of Tropical Medicine and Hygiene joined efforts and put a committee that worked for several years to establish a guideline set for diagnosing and treatment cysticercosis in the U.S. As you can see, the recommendations after analyzing the published evidence were very, very similar to the concept we have been discussing. They recommend to use antiparasitic drug plus steroids in people with viable parenchymal cysticercosis, also in single enhancing lesion, to restrain from using it in encephalitis, neuroendoscopy in intraventricular cysticercosis and long-term antiparasitic drugs in subarachnoid cysticercosis. A couple of more things before we finish. One is calcified cysticercosis. In a few years ago, well, not more a few years, almost 20 years ago, in Canada, there was a report of people with calcified cysticercosis showing contrast enhancement after a seizure, which was followed very quickly by a report from Dr. Nash at NIH saying that in people with all calcified cysticercosis, you can see contrast enhancement and edema after a seizure. And that's clearly evident when you treat these patients. You see this happening with frequency. And so far, we are calculating that 30 to 50% of seizure relapses in people with calcified cysticercosis are associated with these inflammatory bouts. It doesn't mean the parasite is alive. There is no evidence that there could be anything alive. Antigen is negative. There's no regrowth of lesions. It's basically edema and inflammation. And we did a longitudinal study in which we included people with calcifications and followed them in the long term and did an MRI in the initial 3 or 4 days after a seizure. And at the same time, we took a control patient from the same cohort, somebody with calcifications and no seizures. And from 110 patients, we found that 36% of them had seizure relapses. And when we looked at 24 persons who had seizures and we were able to have an early MRI, 12 of them had this edema around at least one of their calcifications. But when we look at controls, you look at the bottom part of the graph, there were only 2 of the matched controls that had edema, and the one in the right with a clear edema spot, this person had a seizure a few weeks later. So there is a strong association between edema around the calcification and a seizure, and we are still trying to understand whether this reflects bouts of inflammation or whether there is subclinical seizure activity involved in the pathogenesis of this. Finally, all of these clinical parts will be much better if we don't have to see patients with cysticercosis, and cysticercosis is considered an eradicable disease. By 2016, we finished a 10-year study in a large section of the north of coastal Peru, in which we were able to eliminate transmission of cysticercosis by using a grant from the Bill and Melinda Gates Foundation, and using all the state-of-the-art tools, including a vaccine for pigs developed in Australia, coproantigen ELISA detection, and treating pigs with oxfendazole. And at the end of the 1 year of intervention, we didn't find any traces of sustained transmission in 104 of 170 villages. And that was made with a great team of local people headed by this big, fat, bald guy in the yellow shirt on his knees, Dr. Guillermo Gonzalez. Dr. Gonzalez is the best field epidemiologist I have ever seen working. He did a spectacular job in doing this program in Tumbes. The only problem was that he was so tired of too much effort that he decided not to work again in his life. So he applied for a position in Geneva in WHO, and he's now a PAHO officer in South America. So the paper was published in 2016, and we hope that this will be the initial step for widespread elimination and, who knows, perhaps someday eradication of cysticercosis. Thank you very much. I'm open to questions if there is anything.
Thank you, Dr. Gracia. I think for a very exhaustive but succinct coverage of the topic. You have highlighted the fact that there is a difference between cysticercosis in India and Latin America, where you get more racemose and subarachnoid parenchymal ones. Now, if there are any further questions or queries from the participants, maybe please have them.
So there are some questions which have been asked.
Many which
questions?
Many of the questions Hugo has already answered.
He's already answered. But shall we continue with the question, or do we ask the question?
Oh, Rahul, please continue with the questions.
Yeah. So I'll show the questions as a slide, so it will be easy for others also to see those.
Okay.
So there are many questions which he already has answered, but then there are some questions which may be asked is, what are the different types of parasites, how they will appear different on imaging, and can there be a large abscess-like lesion which can be seen with cysticercosis?
Well, what I answered to that question is that in general, when you have large mass effects producing cysticercosis, most of the time the content of the parasite is CSF-like, very clear. And that's different from tuberculosis, which is the usual differential or neoplastic lesions, where you can see heterogeneous, more dense contents. So in general, when cysticercosis is occupying a large space, it's mostly CSF-like contents.
So looking abscesses would have a heterogeneous intensity.
Yes, you can distinguish that by looking at the surrounding parenchyma and the contrast enhancement pattern of the lesion. And it may happen in cysticercosis, but usually inflammation in cysticercosis occurs at medium-sized lesions. When you have a very large lesion, it has grown for years, and it's usually doesn't show that much inflammation.
Okay. The second question asks whether you can get spinal cord involvement in cysticercosis, whether it is common. If it is uncommon, why is that?
Well, it is uncommon, and the most likely reason is just probabilistic. The embryos of T. solium are distributed by the blood, and the amount of blood flow to the spine compared to the brain is much smaller.
Can I ask?
Sorry, Hugo, it's Rad. Can I ask a question?
Yes, please. Go ahead, Rad.
Thank you very much. Thank you. The question which always, which you mentioned, is that those individuals with multiple cysts of different ages, does the infection occur all at once, or do they have teniasis and get reinfected over a year or 2 or 3? And what I didn't understand, how long does the tapeworm live in the gut and keep infecting the individual?
That's a great question, Professor. Let me begin by the end. The evidence suggests that the tapeworm in the human host lives around 2 to 3 years.
Right.
That doesn't mean it can infect the host for all of that time. It's very likely that the host will develop some sort of immunity eventually. However, if you look at patients with many, many cysts, it's very frequent that they have a tapeworm. It's kind of suggesting that they were infected by their own tapeworm during a window of time. We don't know if that window of time will be a few days or a few weeks. but eventually the host will develop immunity to the eggs and will not be infected anymore. Why do I say that? There are a series of experiments in cows and pigs in the 70s and 80s that show that as much as the animal has viable cysticercosis, there's no space for new infections. They are protected. It's called concomitant immunity. So probably if a tapeworm carrier infects himself or herself, it happens at the very early stages of the egg producing period.
May I add a comment to that? You know, the Indian experience is that we get cysticercosis with convulsions in vegetarians, very strict vegetarians amongst the Jain community. And they are usually a single solitary cysticercosis. The patients who had multiple cysticerci in the brain are usually non-vegetarians and meat and pork.
Sorry, were you asking a question or were you?
No, I was just adding to your comments. Okay, when you have multiple cysticercosis, you are likely to have a tapeworm in your gut. And that is borne out by the fact that in India, vegetarians tend to have a solitary cysticercosis, whereas non-vegetarians tend to have multiple cysticerci.
Yeah, I will agree with that. It's probably non-vegetarians have a much higher likelihood of being infected from their own tapeworm or a tapeworm in the closed environment.
There are quite a few people who have actually asked about albendazole. The questions were asked after I did this PowerPoint. So you can talk about albendazole if you wish. And then there are people who have asked, what is the role of retreatment? You treat the patient, there is no good response and there is no evidence of re-exposure to the parasite probably. Should we retreat the patient?
Yeah, in general, what we do, and remember we deal with multiple viable cysts, we continue treating until we obtain the resolution of all the cysts or the calcification of all the cysts. But I was answering some questions, and one of the questions had to do with enhancing lesions after treatment, and that may be just residual dying lesions and may not be necessary to retreat. So in general, we do retreat when we see a cyst. If we have taken all the lesions to a degenerative stage, we just wait.
Hector, a cyst which is enhancing is one which is dying. So do you need to kill somebody who's dying?
I was saying the same. When we see that all cysts are now enhancing and collapse, we are more confident that they will degenerate by itself. But I would like to say a word of caution, because enhancement by itself doesn't always mean the cyst will degenerate. So this is a spectrum in which you have a cyst with a little bit of enhancement or more enhancement, perilesional edema, turbidity of the contents, the lesion shrinks, and then it disappears. So it's a spectrum, and you have to judge how advanced it is the degeneration, because just enhancement is not necessarily marking that the cyst will die. In our initial placebo-controlled series, there were a few patients with enhancing cysts in whom the cyst was alive 6 months after.
Okay. I have one more question, Rahul, please. Giving therapy, does it reduce or increase or have any effect on whether the lesion is going to be calcified or not?
That is a great question. I I have two answers for that. The first one is, as of today, there is no evidence that this occurs, but I also have to tell you that we have a person working in animal models and analyzing clinical data from people. And it seems that modulating the inflammation with steroids and giving more aggressive, longer courses of antiparasitic therapy may end up in fewer calcifications. It will not cancel the likelihood of calcification, but it may reduce the proportion of people who will calcify. We are working on that.
Can I add something? Hello?
Yes, yes.
In our experience, the enhancing lesions, if we give steroid, the response is much better. What is
yeah, that makes sense.
Yes, thank you.
May I ask one query? Usually these enhancing cysts are seen after the patient has had a convulsion. What is the role of the break in the blood-brain barrier secondary to a convulsion in the enhancement of the cyst?
There's definitely a contribution. As closer you take the MRI or the CT to a seizure event, you are going to see more enhancement. If you repeat the image a couple of weeks later, you will see less enhancement. That's why I was saying you have to be careful whether you decide a parasite is alive or not. It may just be an inflammatory reaction.
Right. And is that true also for a convulsion following a calcified cyst? You showed a lot of edema and inflammation surrounding a calcified cyst. Is that also true that a convulsion following a calcified cyst can produce a lot of edema surrounding it?
Yes, and I guess you are seeing this and working on this. And our experience is also that in calcifications and even in patients with cysts, if you take an MRI short after a seizure, you will see more edema. So there has to be a contributory event of the seizure in breaking the blood-brain barrier and probably localizing around organic lesions.
Fine. Dr. Prabhakar? Rahul?
Yeah, there are quite a few other questions, but I think with the want of time, we'll move ahead with the cases. And Dr. Hector Gracia has already answered some of the questions in the private box. And I hope that he may answer some of the other questions also. We move ahead with the cases. Dr. Meshram, sir.
I think our screen is totally white.
Yeah, Gagan, Manish is here. Thank you, Professor Garcia. It was an excellent talk. Very good presentation. Thank you very much.
Well, thank you to you. It was a pleasure. I will try to answer all the questions in the
some questions we'll send you on mail.
Okay, sounds great.
Yeah, thank you. Manish Modi, can you start your presentation?
Sure, sir. Thank you, Dr. Meshram, and thank you, Professor Prabhakar, Professor, and all my teachers and seniors. It's a matter of great pride and pleasure to kickstart this case series from PGI, which belong solely to Dr. Chopra. He's the grandfather of neurology in North India, I will say. I keep Dr. Prabhakar as father of neurology. So this case is dedicated to Professor Chopra. He had already diagnosed this case. It was presented in a CPC. I'm sure most of you will diagnose it, but it is really great to present this case once again. It's an eye-opener, and I'm sure it will be of interest to all the neurologists world over. So let me start with the case straight away.
Can you share your screen, Manish?
I'll share my screen, sir.
Yeah.
So I hope it is visible.
Yeah, it is there.
Yeah. So I'm presenting a case of rare encephalitis, and it is a case of an 18-year-old male with 1 month history of headache. It started with holocranial headache, followed by progressive weakness of the right upper limb along with the right facial deviation, which progressed rapidly to an extent that the patient presented an altered sensorium to PGI. There were no seizures, no other cranial nerve palsies, and there were no systemic complaints, no fever, And examination did reveal there was neck rigidity, and there was, on examination, spasticity of all 4 limbs with the definite evidence of right human 7th nerve palsy, and the patient was in altered sensorium. The gross systemic examination didn't reveal anything. So as per the standard teaching in PGI, was there a lesion? The answer is definitely yes. And if yes, where was the lesion and what was the lesion? So as per the anatomical localization, there was right upper limb weakness with right UMN, suggesting that there must be some left-sided lesion above brainstem. Though it was not a dense hemiparesis, so it can be a cortical or a subcortical white matter lesion. There were bilateral signs, so we expect that there should be a multifocal lesion. And there was altered sensorium, which might indicate either a diffuse cortical involvement or there was a raised IHCP. So headache would have been because of the meningeal based pathology, or it could be because of the raised intracranial pressure. So with the multifocal disease with rapid progression culminating to death, it could have been a very fulminant demyelinating disease. It could be a vascular event. It could be infection. There were oddities for everything, and it could be neoplastic or some other occult pathology, which we are not sure. So the list is long. I'll repeat this list after I show you some of the investigations. So it could be ADEM, it could be CNS meningitis, it could be TBM, it could be fungal, parasitic, pyogenic, brain abscess, neoplastic, or some other pathology. So let us see. I have not revealed a couple of the CSF findings which were sent in this patient, but grossly there were few lymphocytes. The glucose was essentially normal compared to the corresponding blood sugar. The proteins were mildly raised from a CSF which was run 2 days earlier, which was showing higher proteins, which were found to be higher even in a CSF which was processed in PGI. I'm not disclosing the TB, PCR, malignant cytology, cryptola, or fungal reports. Couple of reports have withheld just to make this case interesting. Though this is the non-contrast CT, I'm sure everybody can appreciate there is a cortex-based lesion, cortical, subcortical lesion on the left side with mass effect, and we can appreciate these lesions, and if possible we can appreciate one subcortical frontal lesion on the right side also, right? And if one can further read into it whether there is some kind of a hemorrhage or not, if one can appreciate, else we will appreciate better on MRI. So this is the contrast which is showing gyriform enhancement, mass effect, and subtle enhancement of the lesion also. And this was the MRI which further defines that this is a multifocal lesion. There is a lesion in the brainstem, occipital lobe, in the parietal lobe, and then in the frontal lobe also bilaterally, and with mass effect also, and compressing the ventricles. And this is both cortical as well as subcortical, and with some areas of necrosis. And this is the coronal view showing the bilaterality, and this is the flare again showing that there are multiple bilateral cortical subcortical lesions which are also showing some hemorrhages. There are, if everybody can appreciate, there are some hemorrhages cortical subcortical region bilaterally, and then there are areas of necrosis also, and there is some gyriform enhancement and some subtle enhancement of the subcortical white matter lesions in addition to the cortical enhancement, diffuse meningeal enhancement with some leptomeningeal enhancement in the vicinity of the lesion. So, and if we can appreciate, there is some degree of opening up of the ventricles also. So there is some hydrocephalus also there. along with meningeal enhancement, subcortical white matter enhancement, some subtle ring enhancing lesions also, and mass effect. And on diffusion, you can appreciate there is a diffusion restriction in couple of these lesions, which were, on ADC were showing um, darkened, right? So to summarize, there are multifocal lesions with significant mass effect, leptomeningeal enhancement, gyral enhancement, diffusion restriction, and couple of hemorrhages here and there. So here I would like to stop and probably ask for the audience to respond if possible. Otherwise, I've just completed the list. It could be some kind of a infective inflammatory lesion like tuberculosis. NCC seems to be less likely, as we have seen in the previous presentation. Fungal abscesses is a reasonable possibility. I'll discuss few of them individually. Pyogenic abscess, the course is not that fulminant and the appearance is not like that. Amoebic toxoplasmosis doesn't seem to be hydrated. Could it be some other inflammatory disease? Could it be, neoplastic metastasis at the age of 18? Unlikely, but cannot be ruled out. Primary CNS lymphoma, whether it is a primary tumor multicentric or it is sarcoidosis or demyelination or vasculitis. So this is a group of, differential diagnosis whenever you have got multiple, space occupying lesions diffusely, bilaterally throughout the brain. And I can discuss few of them one by one, but I would like, at least the response from Dr. Kulkarni, if people are, putting their bets before I start discussing, and from the chairpersons if they are getting some responses from the participants. No, I don't think.
No, there's no way you can get a response from the audience.
They can, sir, from the live.
In the chat window, they can write something.
Yeah, they can write the chat window and probably.
And also in the Q&A, yeah.
But otherwise, I can. If there is no.
Can I put a question? Srachak here.
Yes, sir.
Thank you. This differential is wonderful and it covers everything there is in neurology, but is it fair to say that are these lesions purely in the brain or elsewhere as well? That may take away some of the differential.
Yeah.
And how do you investigate elsewhere in the body, lungs, liver, CT, abdo, chest, pelvis, whatever you want to see if there is anything else elsewhere?
Yes. So that was also done. I have not mentioned it, sir. In the end, I will tell about the detailed CSF analysis also before I finally tell you the brain biopsy. But just to keep, the interest of the audience, I have, withheld some of the investigations and straight away, if, of course, as a clinician, you will be asking for all these investigations, but what will be our differentials when we are seeing such a patient with such a rapid progression and with such a radiology. So I'll unveil all the investigations one by one at the end of my discussion.
So people are saying it is amoebic, Manish, and at least 2 people who have said it may be lymphoma.
Yeah,
that's what the answers we can see.
Yeah. So I think before we can have the responses during my presentation also, I'll straight away come to few of the important differential diagnoses quickly, one by one. So why not EDEM or AHLE? So there was an acute onset focal neurological signs with encephalopathy, like we saw in this patient, and there were multiple white matter lesions, but more important was that they are not only white matter lesions, as Dr. Raj Shakir said, there is more than the brain. There is diffuse leptomeningeal enhancement also. There is a gyriform enhancement. So it is not a pure white matter lesion or just ring enhancing lesions. It is more of a meningoencephalitis. So unlikely to be ADEM or AHLE. And diffusion restriction, which was there even after 1 month, is quite unlikely in the acute phase of ADEM. By this time, this diffusion restriction should have gone, so it is less likely. So what about the primary CNS vasculitis? Again, it presents with acute or subacute encephalopathy with and atypical multiple sclerosis, like picture step by step, and producing encephalopathic episodes and stroke-like episode, but it is usually not that fatal. It presents like strokes and occasionally like intracranial mass lesions, but it is very rare. So the they were not classical infarcts. There were white matter changes, which were a combination of inflammation as well as infarction, in addition to the mass effect which was seen in these patients was less likely seen in CNS vasculitis. And the leptomeningeal enhancement, which was quite intense in our patient, is not that commonly seen in a CNS vasculitis case, though you can have some intracranial GAD enhancing lesions. But we were having the hemorrhages, the infarcts, and the enhancement in the same area, usually, which is not the case with the primary CNS vasculitis, and it is never such a, it doesn't have such a progressive, downhill course which kills a patient in a month's time. So
Manish, excuse me.
Sir.
The interest of time, you will have to sum up.
I'll sum up, sir. I'll sum up very fast. So
Yeah.
I was just discussing few of them. So CNS lymphoma was one of the possibilities. I would like to say that I would focus more on, so they are single or multiple ring enhancing lesions or enhancing lesions, but necrosis, ring enhancement or meningeal enhancement is uncommon, and hemorrhages is rare. So if there are uncommon features, then other diagnosis should be considered. And if there are rare features, then CNS lymphoma should not be considered. So I can, I won't say straight away rule out, but I can safely rule out CNS lymphoma in this case, based on the radiology and my discussion, right? And then toxoplasmosis is, he was immune competent. It is unlikely, and they usually have a basal ganglia lesion. It was more of a meningeal and meningeal pathology. So toxoplasmosis is unlikely. CNS aspergillosis, based on, I've just chosen CNS aspergillosis of all the fungal infections because of the hemorrhages and the kind of presentation. It could be a disseminated aspergillosis. Here comes the role of, imaging of the chest and abdomen, where you can have, evidence of aspergillosis elsewhere. So here lies the importance of, investigating a patient of multiple space occupying lesions or a meningoencephalitis with a systemic chest and abdominal imaging, which was negative in this patient. So, but that cannot rule out CNS aspergillosis altogether, right? So this remains important differentiation.
Manish, I'm sorry, you'll have to sum up.
Right, sir. So
Please.
intracranial we are not considering, but it remains a strong possibility. And then amoebic encephalitis also remains a strong possibility, especially the granulomatous amoebic encephalitis, where you can have meningitis also along with multiple, as well as we can see in these images, which also mimic in our patient. So we have multiple differential diagnoses, but we can safely rule out a couple of them, and we are left with a couple of possibilities, like,
You can remove toxoplasmosis also.
Yeah, but I did talk of, but it is less likely in this patient. But, only the biopsy can, finally tell us the final diagnosis. So
I think the hemorrhagic components will be very much against tuberculosis.
Yeah, it is very rare. So we are left with practically amoebic abscesses or lymphoma. Again, hemorrhages are uncommon. So maybe, we can clinically or from the final. So if you allow, I can show you the brain biopsy straight away.
I think just show the diagnosis.
Okay. So the final diagnosis in this brain biopsy was amoebic encephalitis. They were full of, trophozoites, and and there was a perivascular inflammation, and lots of trophozoites were seen in the brain parenchymal biopsy. So just a brief about, they are the free-living amoebae, and it is acanthamoeba and Balamuthia which produce the granulomatous amoebic and meningoencephalitis. And in our patient, it was Balamuthia mandrilis, which was positive on biopsy and on autopsy. And usually the Naegleria fowleri usually produce primary amoebic meningoencephalitis. It's a relatively rare condition, and they gain access through lower respiratory tract and skin. And there are intralesional hemorrhages, which was the clinching diagnosis, and demonstration of the amoebic trophozoites and cysts in the brain are a definitive diagnosis for granulomatous amoebic encephalitis. This is from the net, and you can use various stains to show the trophozoites and the cysts in the brain parenchyma. And the timely diagnosis, if suspicion is strong, then antifungals, ketoconazole, fluconazole, itraconazole, with the combination of trimethoprim, sulfamethoxazole, can change the course of disease from a nearly fatal to something which can be treated. So that was the take-home message. Thank you very much.
Thank you. Without much ado, can we go on to the next case, Rahul?
Yeah, it's going to be Shripad who will be showing a case. Shripad, so Manish, can you stop sharing your screen?
Yeah, sure.
Thank you. Shripad, you're there?
Yes, yes.
Yeah, please.
Very nice case, Manish. Interesting case.
So, good evening. Am I audible?
Yes.
Yes. So, without any delay, thank you very much for giving me this opportunity. This case has been diagnosed and managed by Dr. Rahul Kulkarni, but because of his commitments, he requested me to present it as he was short of time for preparation. So I'll just get on. He's a young male, HIV positive since 6 years, and he was on ART with poor adherence. With his latest absolute CD4 count of around 300, he presented with 2 weeks history of generalized weakness, cough, and oral candidiasis. And these were his These were his initial investigations with a chest X-ray and the other test in the form of ultrasound abdomen, which showed multiple lymph nodes and splenic abscesses and granulomas. And with this, he was started on antitubercular therapy. 2 weeks later, he suffered a tonic-clonic seizure with left side hemiparesis, and he remained persistently drowsy with loss of urine control. On examination, he was highly febrile with a map of 70 millimeters of Hg. He was drowsy, left hemiplegic, but he had no signs of meningism. And this was a CT scan. So I request all of you to have a careful look. It did show multiple enhancing lesions there and some there. And as you can appreciate in this area in the coronal scans, and with the background of his chest X-ray and ultrasound abdomen, findings that I just mentioned earlier. There was mild leukocytosis, and his CSF actually showed mild rise of proteins, a low sugar compared to the blood sugar, and not much of cellularity. And his India ink was actually negative for cryptococci. So at this point, with an immunocompromised host, like in the earlier presentation, these are the thoughts. to present and write any other differential of this granuloma, like looking like lesions. And you can write in the question and answer box as soon as any other differential strikes you. But being immunocompromised, obviously, as you just saw, amoeba and toxoplasma, and in the fungi, cryptococoma obviously will come to the mind, and other rare fungi which are seen either in endemic areas or specific situations such as blastomycosis and others I have mentioned, and mucor obviously, but the morphology of lesions and the way of presentation, not much in the sinus areas, actually rules that out. And there are some pathologies that would come in immunocompetent as well, but they are more common or more aggressive in the immunocompromised, and that would also include nocardia and listeria in the list, and cysticercosis obviously remains a possibility. So with that in mind, we still, however, thought, considering the other organ involved and the type of granulomas, what is still tubercular, but microscopic examination of the CSF had held a surprise for us. And this was what the India Ink showed. Have a careful look at it. And higher power. So, Rahul, hello, Rahul, you're here?
Go ahead.
You want to go me? Okay. Okay, so I was thinking whether Rahul wanted to add anything as to how his thought process evolved, but essentially at this point, the India Ink, which was obviously done to look for cryptococci, was negative for cryptococci, and the other workup was also negative. And instead, on this stain, we found these filaria of Strongyloides stercoralis. So what we were looking at was helminthic infection of an intestinal nematode, and on our India Ink, we got this filaria that got stained on India Ink, although they can also be seen on wet mount preparation. So this was what the diagnosis was. It's a rare entity in immunocompromised patients, and I have 2 or 3 slides giving a bit of information on them. And there are several presentations, acute strongyloidosis being one of them, which occurs during the migration of larvae, which, as you all would know, causes serpiginous erythematous skin lesions, larva occurrence, and abdominal symptoms and cough, because obviously the larvae and the worm is in the intestine, and the migration occurs to lungs. And chronic actually many times can be asymptomatic or may lead to chronic gastrointestinal manifestations and recurrent rashes and recurrent asthma-like symptoms because of migration through the lungs. And then there is this entity of hyperinfection syndrome because of systemic infection due to larvae. It is rare, it may be fatal. It is commoner in it is actually more seen in immunocompromised hosts, and the features are attributed to increased larval migration and enormous load of larvae within the intestine and the lungs. And in addition, enteric bacteria, which are also carried by the filariform larvae or can gain systemic access, may also cause a very fatal septicemia in addition to the excessive load and cells. Clinical manifestations are obviously fever, gastrointestinal manifestations, and some of them can be really serious in the form of perforation and secondary peritonitis. And then you will have cough, hemoptysis, and ARDS-like situation because of the reaction of lungs. And as I said, skin rash, meningitis, and bad septicemia and DIC, both as a reaction to the larvae, the worms, as well as the enteric bacteria which migrate along with the larvae. Diagnosis is also noticing the pulmonary infiltrates by stool microscopy, which will show the filariae and sputum, and in disseminated, they can be found in stool, sputum, lavage, pleural fluid, and other fluids as well. Like in our case, we spotted it in the CSF itself. Treatment is in the form of ivermectin, 12 milligram per day for 7 to 10 days. It is the drug of choice for systemic strongyloidosis, and albendazole is also effective at the standard doses for 5 to 10 days. We also need maintenance therapy because of this large load. We need maintenance therapy once a month with albendazole or ivermectin, which will suppress the load and prevent further dissemination or any more attacks of hyperinfection. So here it is, there is one article at least that we have found on literature that showed granulomatous lesions in the brain, and there are many more articles which have shown larva in the CSF where a patient presented with meningoencephalitic like picture. I think that's what I wanted to say. Thank you very much for all the community for letting me present this case of a rare manifestation of rare infection seen with immunocompromised patients. Thank you.
Thank you, Shripad. Thank you very much for a very concise and focused presentation. For the last case, can I ask Dr. Prabhakar to take over?
Yes, I think, thank you very much, Dr. Shripad. It was a really nice, good, informative, presentation. After this, I think we have to go to Dr. Gagan. He has to show some data regarding management. Dr. Gagan?
Yes, yes. Shripad, can you stop sharing your screen so that I can share?
Okay.
Right, thank you. So we are running out of time. I'll try to be brief. Can you see my screen?
Yes, yes, okay.
Right.
Gagan, since it's the first day, we can be a little late.
Okay. Yeah, no, I realize that Ugo is here, and so it would be good if we can have his inputs. Some of the things he has already discussed, and I'll go on to the case. I'm actually a great fan of Jeffrey Archer, and what I like most of his writings are his short stories, and the shortest that he wrote was a short story of 100 words. So my case likewise is also very short in just one slide. A 23-year-old young girl and had a single seizure 4 years ago, and presented to us. MRI was
Gagan,
done.
make it full screen.
Is it? Right. Okay. Right. Is that
yeah
okay now? Yeah. So MRI was done at that time, but it was not available, but it was reported as a solitary cysticercosis granuloma in the right frontal region. And she was on treatment with levetiracetam all this time, 4 years, had no further seizures. And this is what the MRI showed. So you can see this is the flare, and there is a lesion here with an eccentric nodule here. In the SWR, the calcium, you can see that it is blooming. And then when contrast was given, you can see that there is peripheral contrast enhancement. And Ugo alluded to this. And if you can see, this is a T1, and there is something in it, in an eccentric location, which might as well be a scolex in a calcified lesion. Lesion is clearly calcified, and there is the kind of contrast enhancement with Ugo alluded to. And the question that she came in was,
doctor, can I stop my medicines? The usual story is the parents were accompanying the child and the young lady, and doctor, we need to get her married, and can you stop her anti-epileptic drugs? So she asked this question, can I stop my medications? So I'm sure everyone has an opinion on this, and this is something that we see right, left, and center. It is not something esoteric or uncommon like the previous two cases, but this is something that we see very commonly. And I thought about it a lot. Should we stop our medicines? Should we not stop our medicines? I was reminded of what Arthur Conan Sherlock Holmes said in one of his stories. It's a capital mistake to theorize once before one has data, and that makes us twist facts to suit theories instead of theories to suit facts. And indeed, let's have a look at the facts. And this is exactly the study which Ugo mentioned. They followed up 110 patients with calcified lesions between over a period of 5 to 7 years, and when they had seizures. So about 24 of them had seizures, and these were the controls. And they scanned their patients with MRIs within 5 days of having a seizure. And these were controls who were age matched, patients with calcified lesions who at that point of time did not have seizures. And amongst those who had seizures, there were 24. 12 out of those 24 showed perilesional edema and showed enhanced peripheral enhancement. Of those 24 who did not have seizures, perilesional edema was seen only in 2 out of 23, which is 9% of the cases. So clearly there is an association between seizures and perilesional edema. And so the question is whether in this patient with a calcified lesion with no surrounding edema, but certainly a perilesional enhancement, should we be stopping anti-epileptic drugs or not? It's a difficult question. 4 years she's not had seizures, but given this data and the association of enhancement and perilesional edema with the occurrence of seizures, I think it might be a wise thing to continue anti-epileptic drugs. And this is a paper which is a little bit of a provocative paper, calcified lesions, people giving antiparasitic treatment. Ugo clearly advised against this, and I think that's standard advice that people with calcified lesions should not be given antiparasitic therapy. But for some reason, if they are given antiparasitic treatment, then that can lead on to triggering an antigenic release and the development of perilesional edema. And this is data from Theodore Nash, the same paper which I alluded to earlier. And if you would like to know what is an incidence of patients with calcified lesions developing seizures, the rough figure based on these Kaplan-Meier curves is 5-year incidence is about 36%. Calcified lesions, there have been these studies from India, and there are at least these 3 small studies where calcified lesions were followed up for short periods of time, where single enhancing lesions, sorry, not calcified lesions, were followed over for short period of time, 6 to 9 months. And clearly the presence of calcification, as you can see in all 3 studies, were associated with seizures, and the absence of calcifications, patients did not have seizures. So the question is, are calcific lesions really truly inactive? This patient who initially presented with a seizure, 7 months later, there was no surrounding edema, there was lack of enhancement, and I actually stopped the anti-epileptic drugs of this patient at this point of time. But then another few months later, the patient again had surrounding edema and again had a seizure in association with this perilesional edema, and then again became quiet at month 36. So kind of implying that patients with calcified lesions need longer periods of treatment, long duration of treatment. This is the pathology. There is good correlation between the pathology and the imaging. And then there is a little bit of a twist in the tail. And this is again data from Latin America, and there is this study in which Ugo's group was also involved. And if you look at this, if you scan or do CT scans in the community, you go to the community and you do CT scans in the population, a fair proportion between 12 and 18% of them would have calcified lesions. These calcified lesions are more common in people who are seropositive. So this is not hospital-based studies. This is all population-based studies. And likewise, these calcified lesions can be seen in asymptomatic people, but they seem to be more common in people with seizures. There's a little bit of difference between the Peruvian or the Latin American studies and the Indian studies. Dr. Rajshekhar from Vellore and our data, which is also population-based data, and calcified lesions, and particularly asymptomatic calcified lesions, seem to be more common in South America. They're less common in population-based studies from India, where we see active granulomatic lesions also. So from these population-based studies, it can be concluded that calcific lesions are common in asymptomatic patients, as opposed to the earlier cases that we saw, which are clinic-based or hospital-based. Calcified lesions are more common in seropositive people. They're more common in people with epilepsy. And there are some differences in the spectrum of cysticercosis between India and Latin America. And this is how calcified lesions typically develop. There is a granulomatous lesion, initially patient presenting with seizures, eventually gets calcified. But most of them are benign, but some patients will continue to go on to have seizures. But the message should be that most patients are free of seizures. They do well, but they can have the occasional seizures. There is again a twist in the tail, and then you can have calcified lesions. Very uncommon, but these calcified lesions can present with multiple seizures that are difficult to control. And this is a case from Dr. Radhakrishnan. Where this calcified lesion was actually responsible as the zone of seizure origin in this particular patient. If you go have a look at the literature, there are just a handful of cases, say about 10 cases or so, which have been reported, where intractable epilepsy due to seizures arising from the calcified lesion have been reported. In our experience, yes, there is a definite association between these calcified lesions and MTS, but in our experience, this happens very often when these calcified lesions are located in the close proximity of the hippocampus. Meaning thereby, if you can see this calcified lesions and intractable, medically intractable epilepsy requiring surgery is often the case when these calcified lesions are in the close vicinity of the hippocampus. And indeed, if you look at literature, there are still a larger number of cases as compared to the calcified lesion in other locations giving rise to intractable epilepsy of calcified lesions which are located within the hippocampus or close to the hippocampus. So I thought this is a very common thing, but I thought this would kind of describe the entire spectrum of calcified lesions. Calcified lesions can be asymptomatic, and that's often the case when you do a population-based study and in a highly endemic area, like for instance, studies from the Latin America, where a good number of about 10 to 20% of people might have calcified lesions, but they've never had any symptoms. In the clinic, these calcified lesions might present with seizures, And when you follow up these patients, they might have occasional seizures. But a very small proportion of them might eventually develop medically refractory epilepsy requiring various types of surgery. So that's about, in brief, about calcified lesions. I think we have exceeded time, and but still, if there are one or two pressing comments or questions, particularly Ugo, if you have something to say.
Thank you, Gagandeep. It was a great lecture. I enjoyed it very much. And I would really like to focus on one of the things that you mentioned. There is no yes-no calcification. This is a gradual process, and some lesions will have a little bit of calcification, and some lesions will be in more advanced stages of calcification. So that's definitely going to affect. And in terms of the hippocampus, you have a great paper showing that it may be affect the hippocampus from different manifestations. So I will really suggest the audience to look for it in the literature.
Thank you, Yuko.
Gagandeep, this post-ictally enhancement and edema, now there is a whole this thing being described of periictal changes. So after any trauma or any cause of epilepsy, particularly focal, if you get lots of seizures, then you can get these periictal changes. So you can get edema, you can get enhancement, which goes away. So is that part of just post-ictal changes, or is it reactivation of again antigen and things like that?
Yeah, so the question is like the chicken and the egg, which came in first? Was it the seizure, or was it the cyst, or the calcified lesion which led on to? Our view is, and I think Ugo also probably is of the same view, that it's not entirely a seizure, because whatever studies that have been published about post-ictal changes on the MRI, the MRI changes are really very fleeting. And here the edema can go on for weeks together. So 4 to 6 weeks is a conservative estimate. It might actually even go for a much longer period of time. So we tend to take the view that this is probably not just post-ictal changes. They might be contributing in a minor way, but these are probably changes due to release, intermittent antigenic release from the calcified lesion. And it probably needs to be verified in some kind of pathological studies or more studies of imaging. And Dr. R.K. Gupta from Sanjay Gandhi PGI, now he's based in Gurgaon, has done some elegant MRI studies in this respect. And he has actually demonstrated the presence of, little bit of live material, which is released intermittently, which probably contributes to it. So we really need to confirm all of that in I think imaging as it is evolving will really find answers for this.
Sometimes sometimes we have patients who have, because of poor compliance, they miss the anticonvulsant, they get a fit, and then you see the enhancement and the edema. Would you just advise them to restart anticonvulsant, or would you give steroid, and would you give albendazole?
I would certainly not give albendazole, but I would certainly reinstitute the anti-epileptic drugs. Steroids in some selected situations. What do you think, Ugo? I mean, the seizures are not
exactly the same. I think there's no reason to give antiparasitic drug. It mostly will respond to dead remnants of the parasite if it has an immune response. And the second is antiepileptics are key, and many times these persons can be improved by optimizing antiepileptic treatment. And we worry that giving steroids may be counterproductive in the long term. So I will restrict it to very selected cases. And just one additional comment, you mentioned chicken and egg, and it may be chicken and egg both at the same time.
Yes, 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 yes.
I think Gagan,
Professor Prabhakar, can I ask a question, please? Rajshek here. Can I ask a question, please? As we have these experts here, I always wondered about the issue of the common occurrence of asymptomatic cysticercosis, which you find in population studies, and epilepsy occurring in the same individual, but not causally related. And I just wonder, with those with extraparenchymal cysts, that once the cyst is found, the doctor, treating physician, neurologist say, cysticercosis, treat. But I have not seen, you please correct me, any detailed studies of the type of seizures and whether individuals with a single cyst, calcified, not calcified, maybe calcified, is it really the cause of the seizure, single one, or the epilepsy? We seem to causally relate them, but I'm not sure. And to answer Gagandeep is that talking about preparing lecture, you mentioned Jeffrey Archer. I'll quote Churchill. He said to an audience when he was giving a talk, please forgive me, I did not have time to prepare a brief presentation. So preparing a brief presentation takes much longer time than preparing a long one. So I think your presentation was wonderful. But to ask Hector and to ask all of you who are experts on this, is the causal relationship always correct?
Ugo, would you like to answer that?
Yes. Many people think that I am a neurologist. I am not. I am an epidemiologist. My training is in public health. And there are many studies, and they consistently show that people with calcifications or cysticercosis in endemic areas have a 3-to-1 odds ratio of having seizures. So there's a very strong, consistent relationship between cysticercosis in communities and epilepsy. But, of course, if you have 20% of people with brain lesions that are asymptomatic, it's evident that 20% of a proportion of them may have epilepsy from other causes. So it will definitely not be absolute. But in most of the cases, the association between brain cysts and seizures will be causal. There will be a small minority that are not. And there is a paper by Kevin Duque from our group, that studied a cohort of people with calcifications and seizures and found out that most, I would say 90% of the seizures were topographically associated with the type of seizure.
May I make a comment, please?
Yeah, I completely agree that, in fact, yeah, I think that 90% rule is very true. But there is this odd patient in which you should keep your mind open for an alternative cause for seizures, and we have seen that happening. So a person might have idiopathic generalized epilepsy, and there is a calcified lesion. So we should certainly investigate.
Dr. Saroj, you want to ask the question? Yes.
Gagan, you showed a case of Radhakishan, in which the calcified was the focal point for the seizures. Now, he has a very large experience for surgery in epilepsy.
Yes, yes.
From his experience, from his series of over 1,000 cases, how many were focal calcified cyst?
So there are three kind of or four the seizures are actually arising from the calcified lesion. That is the most rare. That's the rarest of the four conditions, right? Hello, can you hear me, sir?
Yeah, I can hear you.
Hello. Yeah, right. The second is that there is a calcified lesion. The patient has associated mesial temporal sclerosis. Most often it is on the same side as the calcified lesion, but it can be on the opposite side also, in which the seizures are clearly arising from the hippocampus and the patient benefits from an anteromesial temporal lobectomy.
Does that lobectomy also remove the calcified cyst?
No. This is a remotely located. The third situation is a dual pathology where there is a remote calcified cyst and there is mesial temporal sclerosis, and they have done, Dr. Radhakrishnan and Rathore and the entire group, they have about a large number of cases. I would say number is about 10 to 20. The number probably this is about 10 years ago, so the number must have grown. And there they had to do surgery. They had to attend to the calcified lesion as well as the hippocampus. So unless both the lesions were removed, the patients would continue having seizures.
So you come back to the chicken and the egg together.
Yeah. And the fourth situation, in what I think is the most common, is the calcified lesion, as you said, is located very close to the hippocampus. So there, invariably, it's the proximity to the hippocampus has led to the involvement of hippocampus. And when you do surgery, you take out the lesion as well as the hippocampus. And I think that by far is the commonest situation.
Right.
So there are these four different kind of situations which can happen. And the first and the third are uncommon, and the second and the fourth are more common.
Okay, thank you, Gagan. Thank you for a very illuminating talk. And I think you raised more questions than give us answers. So there are some guidelines that we can follow. When a young girl comes to us asking us, can I stop my medication? I'd like to hand over the mic to Dr. Prabhakar to make the concluding remarks.
Thank you, Dr. Katrak. I think it has been a very nice discussion. You're right, there are more of questions raised. You don't have answers. You will have to, make the treatment according to the situation. When you want to continue or you don't want to continue, you cannot decide whether in a calcific lesion it is a post-ictal edema or the edema was caused by activation of the antigen, or both the things were together. It is very difficult to say. I think with all the very nice talks and case discussions, it's our duty, both Katrak and myself, to thank the organizers. Meshram did a very nice thing along with the Indian Academy of Neurology. I think it was a very nice initiative, and I'm sure the next few weeks or 8 weeks are going to be very nice. Thank you very much.
Before we end, I just want to tell people that apart from the next week's program, we have something for those who are interested tomorrow. We continue the office neurology, and we are beginning genetics in neurology from tomorrow. There will be 3 talks on genetics every week on Sunday. And Dr. Ashish is going to have a quiz on ataxia. So I invite everybody for that. And I thank everybody on behalf of FINE. And I thank Meshram, Dr. Gagandeep and Rahul for setting up this whole thing. Thank you and good night.
Thank you. Good night.
Thank you very much.
Thank you, Professor Hector Garcia. It was a wonderful talk, and it is always a great pleasure to listen to you again and again. And Professor Raj Shakir for sparing time. And Hugo and Raj Shakir and Wolfgang, you are always welcome to log in anytime. And it will be a great pleasure to have you board in future meetings. And thank you very much, Professor Wolfgang Resort, that he came and for the inaugural session. And thank you, Dr. Prabhakar, Dr. Katrak, and all the presenters. And thank you, participants. It was a great attendance. And due to some short timeline that you are seeing more of Indian faces in today's meeting. But from next time onwards, we'll have more presentation from international people,
Faculties.
Professor Gustav Roman, John England, Tisa Vijayaratne, Chris Kennard, Professor Griswold, Haji Mandi, Augustina Charve. All these people have confirmed to be the chairperson for the next few sessions. And there are a lot of interest shown by presenters, and they are submitting cases. So we'd like to, have cases from different parts of the world and discuss them during the session. And next Saturday, we'll start sharp at 7. And thank you very much. Thank you, everyone. And thank you all the presenters.
Thank you.
Good night, Dr. Hector. Good night, Rad.
Thank you.
Good night, everyone.
Thank you, everybody. It was a pleasure to see you.
Thank you. Thank you.
To see you, Hector. I'll see you soon. Bye-bye. Bye-bye.
Bye.
Bye-bye.